Good afternoon. This is the perfect slot to have after lunch. It's called the postprandial slump. So in health terminology, it's when all the oxygen has gone from your brain to your stomach. So take a deep breath, get some oxygen flowing back into your brains. This is going to be the most exciting section, and we've got some great stuff to talk to you about. But really, colleagues, partners, friends, this has been a fantastic morning. And it's really an exciting moment for us in the health space because we're here to talk about our big challenge, and that is building trust in digital health data so that it can work for people wherever they are. And I really want to recognize the work that Daniel and Rolf have done in their leadership in bringing all of us here today. It's, I consider myself to be a bit of a techno geek, and finding myself among my fellow geeks is a thrill. So that's really great to be here. So I don't know if we have the slides queued, but maybe I have control over them. I do. In today's world, we know that people move. They travel, as we've heard just a moment ago, for work, study, or pilgrimages. Health doesn't stop at borders, and diseases don't stop at borders. Just a few years ago, we experienced the devastating effects that can have. And people need vaccines, people need continuous care for chronic illnesses, we need to be able to port our prescriptions across borders, and we need emergency care wherever you go. For example, those of you hopefully have come here to Switzerland will not need this, but if you do, it would be nice to have access to your health records. But the problem is your health information rarely moves with you. They're often locked in systems that don't talk to each other. The fragmentation that we experience in healthcare slows down continuity of care. It slows down emergency responses. It affects positive outcomes and survival rates. And we've heard from other sectors today that have solved this. Aviation has global systems for passports and travel. Finance has ways to secure systems to move money. And both are based on standards, interoperability, and trust. And health, we're here to tell you today, is working on the same kind of trust architecture. A QR code in your hand or on your phone could be the difference between life and death. So WHO, working with countries and partners, has developed a global digital health certification network, known to its friends as the GDHCN. As custodians for the global strategy on digital health, we see this as an extension of our mandate from 194 member states to help secure the need for cross-border exchange of verifiable health credentials. And GDHCN responds to this need grounded in standards like HL7 FHIR and the International Patient Summary, while preserving privacy and sovereignty, two themes that we've heard over and over today. This is global digital public health infrastructure. The GDHCN is not a health data repository. WHO does not see, it does not store, or it does not manage personal health data, as you've heard from the last two panels that presented their use cases. This is a trust framework, allowing countries to issue, verify, and accept digital health credentials bilaterally and securely through cryptographic signatures, ensuring verifiable provenance while maintaining sovereign data control. So with the leadership of the European Commission, who established the technical foundations behind the GDHCN, when during the COVID-19 pandemic, as our colleagues from South Korea this morning shared in the plenary, WHO worked with member states to establish and publish standards around verifiable vaccine and test records. What the GDHCN does is facilitate person-mediated carriage and access to their verifiable health data, making it easier for bilateral trust based on the electronic representation of the trust that countries have placed in WHO as the trust anchor, to verify the authenticity of the issuer of those certificates, whether these are patient summaries, vaccine records, or even health worker credentials. So there are many practical use cases we're currently working on, including pediatric essential vaccines, patient summaries for cross-border care. We're going to hear from our colleague, Dr. Osama, about one of these high-demand use cases, e-prescriptions for people who travel across borders, maritime health records for seafarers, clinical training credentials to verify health worker qualifications as we have increasingly fluid borders for that specific workforce. Controlled medication certifications for legal, safe use of narcotics for those living with chronic pain, and recognized disability benefits and privileges for people living and working with disabilities. But technology alone is not enough, right? We have to have the enabling policies, the clear governance, and strong legal frameworks, which is where the people come in to the trust equation. So we also need shared technical standards. And I think we've heard a lot about that challenge today, the fact that there's such a proliferation of standards. What this meeting is doing is bringing us into a room together so that we can see those opportunities for cross-pollination and move forward. I think one thing to keep in mind is that we can test interoperability, but we have to build and we have to earn trust. The other things that WHO is concerned about is equity and inclusiveness. How do we make sure these tools work for everyone? How do we ensure affordability with systems being financially sustainable with clear CapEx and OpEx planning? What are the business models to help sustain this infrastructure for the public good? And how do we ensure that countries are at the center of the technologies that are enabling their people, especially when it comes to health? How do we maximize country capacity and local ownership? Because if we don't address these issues, we risk creating new digital divides where countries who can end up participating in this infrastructure, where leaving those who cannot behind. So we have to have clear roadmaps, we have to have reference architecture, test environments, and shared learning spaces so countries can all move forward together. And this is what I hope tomorrow is really going to cement down. Today, the GDHCN has 82 countries participating and growing on a daily basis. We effectively cover 2 billion people around the globe. Since we've launched the GDHCN, we've seen what's possible in the last 2 years. The Hajj Health Card Initiative is just one use case that you'll be hearing from today from Dr. Osama, with Saudi Arabia helping over 500,000 people travel safely on that pilgrimage while protecting public health, with 3 countries participating using their own national digital wallets as a way to represent a standards-based international patient summary. The GDHCN is a shared resource that countries can use in a way that respects sovereignty while enabling verification and continuity of care. So we look forward to your being part of many of these discussions, many of which will be happening tomorrow as we dive deeply into this health vertical. At its core, this work is about people. It's about ensuring a mother can carry her child's vaccination record across borders, that a worker can continuously provide care as they move with a patient across borders in an emergency, that in an emergency like we are just getting out of with the COVID pandemic, we can respond faster while respecting individual rights and sovereignty. And that vision, we believe, is achievable, but it will require the continued collaboration, investment, and a shared commitment to building standards-based digital systems that will work for everyone. Thank you very much. So we have 2 exciting speakers. The first I'm privileged to introduce as a good friend and partner in this journey. Dr. Osama Hassan is the head of eHealth at the Dubai Health Authority and co-founder and vice chair of the Emirates Health Informatics Society. He's also the chair of the Digital Health Workforce Development Collaborative, also known as ZIMAM, which focuses on professionalizing the health domain for digital health. So, Dr. Osama, if I can invite you up here to tell us about the Hajj Health Card, or you can stay in that comfortable chair.
Very much. Really, I want to go back to August 2023. We remember that we were in the same room. We were in the same room in Sydney, where we are attending the MedM for 2023, and we were integrating the IBS as a framework developed by HL7 with the support of the WHO and the Global Digital Health Partnership. That was a very useful protocol to help cross-border data exchange. But as you know, the challenge with healthcare data, comparing with other domains, that they are very sensitive, and most of the countries are reluctant to send data cross borders. The challenge with that in many countries, they think that health data is kind of part of the national security. And even if you remove identifiable, still this data is considered as an asset. And I believe that every Ministry of Health in the world, that maybe one of the top 5 priorities for them on how to monetize the data that they have, the healthcare data. So to be very difficult for them to accept. And I remember that at that time we were asking how we can find a good use case that we can convince countries to accept cross-border data exchange. And I remember at that time we started to talk about Hajj. Hajj is a pilgrimage season in Saudi, where Saudi receive more than 2 million people from outside Saudi, coming from 160 countries. And Saudi is responsible to take care of their health during those 2 or 3 weeks. And it's really difficult talking about solving emergencies issues for those pilgrims, especially with the language barrier, with different culture. It's really difficult for them to treat people that they don't know anything about. And that's why the IBS utilization for Hajj was a very good use, not only a good use case, but it's a sentimental use case, because through this protocol, you can save lives. And this already happened. And we managed that when we talked with the Saudi government to adopt this use case, they were very supportive. We managed to connect with 3 countries, Oman, Indonesia, and Malaysia, and they were really engaged. And I believe during all the technical discussions, the most difficult part was the governance part, not the technical ones. Nobody was asking what about the details of the wallet or how we can manage the digital public infrastructure. I remember 50% of the discussion was what will happen when the data flow from my country to the EMR of the doctor in Saudi. So once this data come there, they were asking, is he able to save it in their platform or just look at it? And some countries were accepting use case 1 and use case 2. Some of them would say, no, I want the doctor only to view it. So this just shows how sensitive this data. But the good news that once we agree on the use case, it took us less than 2.5 months to implement the use case. So that shows how those 3 countries were really, really supportive for this idea. It was a really huge technical work, a lot of testing, a lot of verification of the whole platform. That was not an easy job. And within 2.5 months, it was implemented last Hajj. That was June last year. And this year, we do it for the 2nd time, just to make sure that we are on the right track to call for other countries to get on board. So I think that that's a very, very good use case. And I believe that there will be a number of other good use cases that can be implemented, maybe for disability, maybe for e-prescription, especially people on painkillers, for example, wants to travel from country to country, they need a verifiable evidence that they really need those drugs. Otherwise, they won't be able to get it. So I'm sure that there are many sentimental use cases that will come afterwards. And that's it. Thank you very much.
Well, you heard it from Dr. Osama that verifiable cross-border certificates can save lives. So what better justification do you need? 500,000 pilgrims equipped with their own personal health record, able to cross borders and ensure that they received tailored care according to the conditions that they live with. It really can make the difference between life and death in these situations. Next, I'd like to introduce another good friend and colleague, and really a partner, because this work isn't done by WHO alone or any group by themselves. It has to be done as a coalition. And Dr. Daniel Vreeman is the Chief Standards Development Officer at HL7 International and has been leading the development of FHIR and other health data standards. to advance global interoperability. He's also the president of HL7 FIRE Foundation, working to unlock health data for better care worldwide. And for those of you who aren't aware of the FIRE standard, this has been one of the biggest game changers in health sector interoperability over the last 5 years. So Dan, over to you.
Well, thank you. As Alain mentioned at the beginning, despite so much progress in the last quarter century, far too often people travel across borders where their health information doesn't follow. And as a result, the healthcare that we experience and the health that we have is limited by the incompleteness of data that's available to patients, to clinicians, to caregivers when it matters most. In healthcare, like in other domains, the path forward to meaningful interoperability is using open data standards. And I'm honored to be here with my colleagues on behalf of HL7 International, which is a global nonprofit standards development organization focused on convening stakeholders around the world to develop open standards that enable interoperability in health. And this conversation is part of a broader collaboration with WHO to advance the use of open standards. Now, across all sectors, the fastest growing quantity that we can measure is the information that we're generating. In healthcare, it's no different. A single hospital stay can generate massive volumes of clinical data of very diverse different kinds. Clinical notes, laboratory results, imaging, procedures, medications, waveforms, you name it, right? And without standards, that information is due to be diverse and inherently localized, which prevents interoperability of any meaningful kind. But over the last decade, a remarkable global movement has emerged that has embraced HL7's FIRE standard as a data model and open API specification for health information. FIRE, or Fast Healthcare Interoperability Resources, is a modern interoperability framework that really supports many different use cases. It's made freely available by HL7 under the Creative Commons Zero public domain designation, and has won the support of governments, healthcare providers, software and cloud vendors, and many, many others. But today, really the most important take-home message for you is that FIRE is fueled by a vibrant global community that's convened by HL7 and consists of health providers, technologists, policymakers, patient advocates, and others who are working together to use FIRE to solve hundreds of different real-world interoperability challenges. It's this journey of consensus building, coupled with iterative feedback, and the power of solid standards governance that really has made FIRE a transformative and foundational standard for digital health transformation. FIRE is a versatile platform standard that enables many, many different new digital freedoms. It's sort of famous for being an open API, but its rich semantic representation can work just as effectively in other exchange mechanisms like documents, messages, and as we're here today to speak about, verified health credentials in personally controlled wallets. You heard about how during the COVID pandemic, WHO embraced the use of FIRE in their digital documentation of COVID-19 certificates, and how in the context of a very rich collaboration of global entities, the International Patient Summary has been embraced and adopted and moved forward by HL7, other standards development organizations, the WHO, nations as part of the Global Digital Health Partnership, and lots of others. HL7's IPS FIRE specification contains and defines a minimally clinically important set of data that supports that unscheduled cross-border care. So with FIRE, IPS becomes a computable, right-sized snapshot of key health information, conditions, meds, allergies, immunizations, that's designed to be useful and transformative with patients wherever they go. There are many more opportunities ahead where personally controlled clinical summaries of patient information can support lots of use cases such as care coordination, public health, and clinical research. But the future we're building together requires not only open standards, but open collaboration. And so HL7 welcomes your partnership in building this vital digital public infrastructure. Thank you.
Thanks so much, Dan. I'm getting the signals that it's time for us to wrap up, but do find us at these sessions tomorrow. But also we have a WHO booth in the annex outside. More than happy to give you a demonstration of what this kind of a health wallet looks like and see ways in which we can collaborate. Thanks a lot, and thanks to our two panelists.